You are all very welcome to this webinar. My name is Jan Sorensen, and I'm a director of the Healthcare Outcome Research Center here at the School of Population Health at the RCSI. I'm also a professor of health economics, so therefore this webinar series about the health economic perspectives of cancer care in Ireland is really close to my heart. It's my pleasure to welcome you to this webinar. This is a third of a planned series of 4 webinars that we are having during this year. We have called the webinar series The Future of Healthcare in Ireland, Health Economic Perspectives. And this webinar has a title, Cancer Screening and Early Diagnostics, Evaluating What Works. In the previous webinars, we have focusing on achieving better outcomes for patients and the value composition. And the second one, we have tried to assess the value of new cancer treatment and innovations. If you did not attend those webinars, or if you want to revisit them, the recordings are available at our webpage. In this seminar, we are focusing on the value of early detection and intervention of cancer. It's a controversial area with both ethical, equity, and efficiency issues, the 3 E's. Certainly, I know that the economics of cancer screening is very challenging. We have invited 4 speakers to share their take on this theme. I will encourage you all to submit comments and questions, which we'll bring to the discussion after the presentations. I would like to take the opportunity to thank the speakers for their time and willingness to take part in this webinar. I'm looking forward to learning about their different approaches to this topic. Before we start, I just want to announce that our next and last meeting or webinar in this series is about diversity, equity, and inclusion in cancer care. And this webinar will take place on Thursday, the 16th of November at 12 o'clock. Before we start, I would like to thank the organizing group, which consists of Mark McFerran and David Dunn from Janssen Pharmaceuticals, Bridget Cunningham from Novartis, Ronan Glynn for EY Ireland, and my colleagues Brian Lynch, Laura Hammond, and Kathleen Bennett from the RCSI. Also, thank you to the companies for their financial support of this webinar series. We're also grateful to Ronan Glynn for taking the role as a moderator in this webinar series. Ronan is the sector lead in EY Ireland and was previously the Deputy Chief Medical Officer at the Department of Health. I now hand over to you, Ronan. The podium is yours. Thank you.
Thanks very much, Jan, and good afternoon, everybody. It's fantastic to see such a great attendance. I think we're up to 125 people, which is brilliant. So this is the third installment in our webinar series, and as you'll remember, the first webinar focused on the epidemiology of cancer in Ireland, and we looked at trends in mortality and incidence both here and then compared them with those internationally. The second webinar, our speakers focused on how we conceptualize value in cancer care. And how we measure value in cancer care, with a focus really on the importance of public patient involvement and of developing a robust data infrastructure and innovative mechanisms to capture and assess value in a way that really puts the patient needs at the centre of cancer care. And so, as Jan said, today I'm delighted to introduce the third webinar, which is going to focus on cancer screening and diagnosis in cancer. And so our first speaker today is Dr. Alan Smith. Having previously held roles as Deputy Chief Medical Officer at the Department of Health, as Director of Quality, Risk and Patient Safety at St Vincent's Hospital, and as CEO of the National Treatment Purchase Fund, the NTPF, Alan now works as a consultant in public health medicine with the HSE's National Screening Service. Alan is today going to provide a public and population health level perspective on cancer screening and diagnosis in Ireland. So Alan, I'll hand over to you. Thank you.
Thanks, Ronan, and thanks, Jan. And I'll get straight onto it. And as I said, we're under pressure for time. So I'm going to take us through, I suppose, the past and the present, and a little bit about the future as well in terms of population cancer screening. I think it's a very popular topic at the moment, and everybody loves to talk a little bit about screening. But I wanted to talk to you a little bit about where we've come from in Ireland. So that'll cover the past bit, and I'm going back to the early noughties and the middle part of that decade. I'll slip then into my thoughts on the future. I won't really talk about future programs as such, but maybe some background information on the landscape that probably needs to change for us to really take advantage of future programs. And then finish on a question I get a lot. How are we doing today by international comparison in terms of our three current cancer programs? So the past. So, I mean, the first thing that caught me was even in the title of the talk, and we sometimes interchange the word screening with early detection. And the purist and somebody like me would say that they're different. So on your screen there, I've tried to present, where does screening sit here in a typical disease progression? So typically cancer develops from a normal cell. Think of it on the left-hand side of your screen, and something happens along the way as we move across to the right, and you suddenly develop symptoms. And there's a vertical line there that develops that point, marks the point at which you develop symptoms. Screening is all about the left-hand side of that vertical line. So screening tackles a healthy population, people who do not have any symptoms. So, and that's who we target. Whereas if you begin to talk about symptoms, well, what do you want to do as a doctor and a health service then? You really want to pick it up as early as possible. And that's early detection of symptoms. So something that I go on a lot about is the precision of the language that we really need to focus on now when we talk about screening. But there's no doubt, and we see it from the attendance here today in terms of the interest in the talk, screening is popular. And and why wouldn't it be? We all talk about and emphasize that early detection results in cure. And what else? We hear about screening can do no wrong, essentially. That's really embedded in our psyche. And why wouldn't it be? I mean, it's endorsed by celebrities. Politicians use it to get votes, let's be honest. I mean, and it's promoted, rightly so, by cancer charities and advocacy groups. And then, of course, we have these little voices in our head saying a stitch in time saves 9, an ounce of prevention is worth a pound of cure. We all know about that. And I was looking at some old presentations I'd done a number of years ago, and I came across this that I used at some stage, where it's a bit old now, but I wonder, has it changed? That 3/4 of the entire US population would rather a total body CT scan than $1,000 into their hand. So it just emphasizes how prominent screening is in our minds. But let's go back to the early part of the noughties. So, at the start of that decade, we didn't have any national population screening programs, none. And that sometimes surprises people. And as we progressed through that decade into 2004, 2005, there were a lot of headlines. And I suppose they are what you see on the screen there. You'd probably be forgiven for thinking that I've taken those headlines from the last 3-4 years. I haven't. Those headlines are all taken from 2003, 4, 5, and 6. So at the time, there was huge uproar around the waiting times for what is a relatively simple test of a smear test. So really, we had a bit of a crisis then too. We had plenty of headlines that weren't going down well. And all that led really, with a couple of other things going on, to what I call a policy tipping point. And we had the first national cancer control strategy. And what did it recommend? Well, I pulled out a few things. It made reference that breast screening should be extended to include all women aged between 50 and 69. And in 2006, you might think that was breast check not a national program then? The answer was no. It had started off on the eastern seaboard side of the country. So this was the first time it was recommended to extend nationally. Similarly, we had the Irish cervical screening program in operation. This was based in the Midwest, so Limerick, Clare, and North Tipperary at the time. And the recommendation from that strategy was to also implement a national rollout of that program. And at the time, a colorectal cancer program was on the wish list, and the recommendation was that it should be established. So, you know, just as I said, I just want people to remember, because we all forget, and I'm guilty of that myself, that that's not that long ago. We were quite, I think we have to be honest, quite a distance behind the UK and other European countries, particularly the Nordic countries, who were way ahead of us in establishing their population cancer screening programs. But where we ended up with, I'll go into the present at the moment, and of course we have breast check, we have cervical check, and the new kid on the block, relatively speaking, I suppose, is bowel screen. But we have 3 national population cancer screening programs. I'll come back to each of those in a little while. But let's revisit that. You know, screening is so popular. Sure, what could go wrong? And I suppose I would kind of ask you to blank out the last 5 years and the various headlines and ask yourselves, did you really hear much about screening and the pros and the cons of screening up until that point? And I think, if we're being honest, we're probably saying we didn't hear that much. You know, certainly when I went into the area of population cancer screening, colleagues that I was working with and other consultant colleagues were sort of asking me, why was I going into that sleepy backwater? Sure, sounds very quiet, uncontroversial. You'll get bored. And little did we know where it would head. But I suppose if you looked at experience in the UK and other European countries, you could probably foresee the tricky areas that we would eventually get into as all of these programs matured. But there is harm, and it's a constant weighing up of the pros and the cons. We all know about the benefits, and we probably are all guilty of talking those up, because it is exciting. It's exciting for the population at large, and even for the individual within those eligible populations, that we can do some marvelous things. As a general practitioner in my early days, I was working one-on-one with patients, and it was thrilling to get good news for somebody on an individual level. But I mean, it's even better from a population perspective. The impact that you can have on a whole population is enormous. But with that comes the other side. You know, we all know about false positives, false negatives. There is such a thing as overdiagnosis and overtreatment. And I should also mention the harmful physical and psychological effects of screening. So there is harm, and we're getting better at talking about the harm. So this is a slide that I sometimes use. I don't expect you to see the details on the right-hand side of the screen, but almost focus on the colors. And we really want to end up on the green. You know, the red boxes are actually the harms. The yellow boxes are sort of no harm, no benefit, but, you know, not too bad on the bottoms of right of the slide there. But ideally, you want to be in that box on the bottom left with the circle. So that's a full Croke Park. Let's roughly say 80,000 people. Now, breast check invites, you know, nearly 500,000 people every year. So that's 6 or 7 full Croke Parks of eligible women going through and starting to enter that diagram on the right. Cervical check, a similar number, possibly even more, you know, 6 or 7, maybe even 8 times that number. And bowel screen, yeah, roughly about 250,000 eligible men and women every year. So I just want to give you that sense of that's a lot of people going through each program every year. And when you, without knowing any science, you know, if you ask yourself the question, will something go wrong? Even basic statistics will tell you it's going to be very, very hard to get everybody through that program without something going wrong. And the spectrum of things going wrong can be very mild to very, very serious. So let's quickly dip into the future first, because I really wanted to and I think other speakers, and I think Ethna and Patrick in particular might talk about future programs might come into being. The one on the horizon is obviously lung cancer. But I wanted to talk about the environment that I think we're going to have to address for new programs to come into being, but also give a nod to some of the technical developments and where that might take us in the future in terms of what we're going to do with these programs. So I think we need to move. We're going to definitely move from what the current one-size-fits-all approach to more precision in how we prevent cancer, and that works for population screening as well. I wouldn't be surprised that in 10 or 15 years time people look back and look at what we were doing across breast check, cervical check and bowel screen and shake their heads and wonder what were we at. But you know, that is what happens with developments. So we need to understand better population and risk-based associations. I think we're really going to have to take advantage and understand the mechanisms of tumorigenesis. So talking about genetics, epigenetics, signaling, tumor microenvironment and immune factors. And obviously we can't go a day without either interacting already with artificial intelligence, but when that really kicks in to how we practice medicine, I think it's going to change how we design our population cancer screening programs. I think we need to talk too about, I make reference to a high performance culture in screening. It's definitely a team sport. You know, it's not just me sitting in an office. It's a combination of clinical staff across multiple disciplines, not just medical, nursing, laboratory. I leave out somebody, primary care. So it's definitely a multidisciplinary team event. We need to talk about past events. We need to get comfortable with that. We need to respond to change. We need to get comfortable with collecting and analyzing and reporting on performance and creating that environment. And leaders and top managers need to be able to do that. And we need to get comfortable with seeking out error and trying to find the factors that are contributing to those. And we need to devolve out responsibility. You can't control it from a central office. And when the ball is dropped, I guess, you know, we need to acknowledge what happened, apologize for what happened and learn the lesson. And you might think I'm pulling a lot of this from the health service incident management framework. I'm not actually. The weekend that's in it. I mean, I pulled a lot from the culture that these two men set up in relation to rugby. So the top is Joe Schmidt, of course, and obviously our current rugby coach. And you know, the event that's coming up at the weekend, I couldn't but not acknowledge their input. But I wanted to emphasize the point that it's taken these two men nearly 10 years to create what's called a high performance environment, and it's spreading out into other sports. And let me talk about the elephant in the room. I suppose I'll give a nod to this, and given the economic flavor to this series, I think it's important because it will come into the evaluation question and the making the case for screening and opportunity costs, because there is a cost to this. The level of litigation in Ireland, as a lot of you probably are aware, is unprecedented, and there's no equivalent anywhere else in the world. And we've been doing some work in the screening service, and quite simply, the current legal framework for Ireland is simply not fit for purpose when it comes to addressing legal liability for errors that occur in cancer screening. And I'd probably go further and say that the legal framework in Ireland is simply not fit for purpose in any clinical negligence case. It's just simply not right that we're forcing our patients and indeed our staff to go through what is a very traumatic event, and it can be significant and it can be prolonged. And I know that we give a lot of attention and speak about the impact on patients and their families, and rightly so. But I think we also need to get comfortable with acknowledging and speaking about the impact on healthcare staff too. It is significant, and I've plenty of personal experience on seeing that impacting. It's not possible to have zero error screening. We have to accept that, and we have to acknowledge it.
14 minutes, Ellen.
Thank you. But we definitely need to acknowledge what I've said is this elephant in the room. So how do we tackle it? Well, as I said, the old adage of taking one bite at a time. And I think the solution is there, at least to start the ball rolling. The first couple of bites are there. We need to implement pre-action protocols and case management rules. So essentially for the non-lawyers amongst us, and I'm one of them, I'm talking about rules and timelines being put on both sides to deliver paperwork and do certain actions. Case management really refers to a fast track or separating out clinical negligence cases from other specific personal injury cases. There's no doubt that it would bring considerable benefit and relief to everyone involved. And I think it's important that we have to do our best to try and preserve that therapeutic relationship between the doctor and the patient. So Part 2A of the Civil Liability and the Courts Act, that's where it sits. It's now overdue in terms of commencement. So let's finish on a positive. Breast check, cervix check, bowel screen. So they're the numbers, you know, every 2 years in breast check, nearly 600,000. Every 3 to 5 years, we're inviting, you know, an ever increasing 1,000,003 women to cervical check and 500,000 in bowel screen. And again, I don't want to expect you to see the details on the screen. We're going to share the presentations after, but I just wanted to focus on data that was published last year by the National Cancer Registry to finish off. And I suppose this is information that wasn't available in 2000 and 2018, which is a pity, because what it's showing there in terms of cervical cancer is that it's since 2008, when we arrived at a situation where incidence was increasing, mortality was increasing, cervical check has reversed that. So there's a decreasing incidence of nearly 3% per year. Early stage diagnosis is going up, which is great. Survival is improving, and most impressively, mortality is decreasing. So we've reversed that trend since 2008 and joined the rest of Europe. Similar findings on colorectal cancer: incidence down, early stage diagnosis up, improved survival, down, mortality, good news. And similarly, perhaps less impressive with breast, but there always been a little bit of it's hard to distinguish between the impact on treatments, surgeries, new treatments from screening, but overall there is a definite positive impact and a positive contributing factor from screening. And I'll finish with the final word, give the final word to our program participants. So a new program that we've introduced into the National Screening Service across all 4 programs. We've started with bowel screen. We're asking them for their experience in real time, in digital format, so no paper. And they're telling us in terms of bowel screen, hugely positive response rate of nearly 50%, which is unheard of, and nearly 4 or 5 times what you'd get in a paper-based survey. But at nearly 90% of respondents are rating bowel screen as good or very good. And bowel screen participants reported high levels of satisfaction with the program. And they've given us a net promoter score. And again, for the non-advertisers amongst you, this is the question along the lines of how likely are you to recommend the program? And they're scoring an impressive 75%. That's pretty much world class. And I've given you a few world leaders, comparators there, the Netflix, the Starbucks, the Amazons. The only one we're not beating there really is Tesla. So with that, I'll finish. But as I said, it's a very popular area, screening programs. We're doing quite well, but there's definitely some controversial areas that we need to keep an eye on and to be respectful of. Thank you, Ronan.
It's fantastic, Alan. Thanks very much. Great overview of the journey we've been on and where we're going. And just a reminder to everyone, if you have questions, please pop them in the chat and we'll get to as many as we can at the end of the presentations. So next up, I'm delighted to welcome Professor Patrick Redmond. Patrick's a GP and Associate Professor in General Practice in RCSI, having previously worked as a clinical academic in Ireland, Australia and the UK, including at the University of Cambridge, the University of Western Australia, and at King's College London. Patrick now leads a programme of work to better understand patients' cancer journey from diagnosis through to survivorship and improve outcomes and reduce healthcare costs. And today, Professor Redmond will discuss lung cancer screening, and he's going to provide some insight into the Irish Lung Health Check pilot that he's currently contributing to. So, Patrick.
Super. Thanks, Ronan. Hopefully you can hear me and see the slides. Yeah, so thank you for the introduction. So I'm based at RCSI and, as Ronan said, an academic GP, very much interested in primary care's contribution to controlling and improving cancer outcomes. And yeah, I want to talk to you about a specific cancer type and interesting development in technology, and then maybe some of the challenges around implementation. Just a couple of quick disclosures. So based at RCSI, very grateful for funders and so on, but these views are my own. So to follow on from Alan's comments about the population level, I think it's important to maybe shift the perspective and to think about primary care and what we're the individual and individualizing risk and individualizing treatment, because it's quite pertinent to what I'm about to describe in terms of the intervention that comes next. But we're quite fortunate in primary care, those of us who work there, general practitioners, practice nurses and other allied health professionals, to see, to be able to intervene at all stages of the cancer journey, from prevention, screening as we're discussing today, and also that early diagnosis piece that Alan was talking about, right through to living with and beyond cancer. So lots of things that we could unpick in terms of optimizing care and various improvements in new technologies and so on. Let's talk about lung cancer then. So a really important health issue, and I brazenly drawn from the NCRI's publications on this, which are freely available. In Ireland specifically, it ranks us with over 2,000 cases every year, being one of the most common and invasive cancer causes of death, attributing up to 20% of all cancer deaths. The bottom left-hand side of this screen, you'll see the 5-year survival rates. And, you know, while it does look like it's improving, and you can see there 24% 5-year survival rates most recently reported, but actually when you compare that to some of the other big cancers, such as breast, which is supported by a screening program, or prostate, they're up around 80 to 90%. So quite different, and definitely something that needs our attention. Another concept that I wanted to get across, and it will be relevant, and we'll come back to it later on in terms of the intervention that I'm going to suggest, is this idea of, as with almost every other disease, is the socioeconomic determinants of illness and how they affect disease. And so we can see this again from the NCRI publication looking at this specific issue. What you're seeing on the left is the incidence of lung cancer in men, and on the right is the 5-year survival rates for around lung cancer. And the 1 to 5 there is deprivation status. And as you can see, as people become more deprived, the incidence of cancer rises, lung cancer rises. And then conversely, as we are more deprived, your 5-year survival rate disimproves as well. And while I'm showing you the figures for men, figures for women are not as stark, but the same trend is there. So there's certainly another issue there that we need to consider in any of the interventions that we might propose. So just to follow this trend in terms of lung cancer and why it's important and why we've got poor outcomes. And again, I'm grateful to CRUK, another wonderful organization from across the water that does a lot in terms of public information around cancers. Here you can see really the issue with lung cancer is the late presentation. So when people have symptoms, it's often quite an advanced stage. So that unfortunately leads to poor 5-year survival rates. People are often diagnosed in emergency settings and so on. So that is the challenge in thinking about earlier diagnosis. So let's go on and talk about earlier diagnosis in lung cancer. So many people have been working with different options and exploring different things. For example, serial chest x-rays as a way to identify nodules at an earlier stage of disease before people become symptomatic. But really what's come to the fore in the past probably 15 years is CTs, or even low-dose CTs, and that's what you can see on the left-hand side of this slide, which is CAT scans. So being able to provide a 360-degree image of somebody's lungs, looking for those nodules. The nice thing with this presentation today is that actually we're at the stage now where there has been at least 7 high-quality RCTs, or randomized controlled trials, that's given us evidence about the effectiveness of this intervention. And it does appear to be, and I've just illustrated that with a graph here, but there have been a number of meta-analyses in the past year, 2 years now, combining that empirical evidence to show that there is an improvement in lung cancer mortality when people are given this opportunity to participate in with low-dose CT for lung cancer detection. I've intentionally put something else on this slide. You can see targeted lung health check. So this is the framing of lung cancer screening in the UK, but the key word there is targeted. And so this is, I think Alan was probably alluding to in his talk, is that this is looking at individuals who are at higher risk and then offering the intervention of low-dose CT to them. And I'll come back and explain a bit more what that means. It's worth mentioning that we're not alone in this, that many other countries are obviously working on similar initiatives, and we're very grateful to be part of an EU for Health funded programme that's called SOLACE, which is Strengthening Lung Cancer Implementation in Europe, which allows us to work with colleagues across Europe as they explore the implementation challenges around lung cancer screening in their own countries, and looking at the issues around recruitment, equity, and so on with their programs. So what does this image show you? This is Manchester City Stadium. And for those of you who don't know, Manchester City Stadium is in a deprived part of the city of Manchester. And so that's very much intentional. What you're looking at here is a CT scanner on the back of a truck. And that is the probably most successful version of the implementation of lung cancer screening, that it is mobile and it is community-based. So what do I mean by that? I mean that you involve the community and that you identify individuals who are at high risk in their communities, and you engage with them, gain trust and so on, and that requires it to be a mobile truck. And so that's been a successful model in terms of participation rates. So I've been talking about lung cancer screening, but actually there's kind of, the framing is slightly different, and many pilots talk about what's called a lung health check. And that's because those individuals who are at higher risk, and what I've done is I've given you some of the broad brushstrokes of what I mean by higher risk on the left-hand side of the slide. It's normally to do with age, so those 55 to 74, and those with the smoking history, whether that's current or past. And so they're two main drivers of risk. There's also two other issues here at play. I've talked to you already about socioeconomic deprivation, to those who are in urban environments, who are in deprived communities, higher incidence of cancer, and then access. So certainly in our SOLACE discussions, we're often concerned about remote distances from CT machines and so on. So we've been exploring how to ensure that everybody has equal access to this intervention. So the infographic on the right kind of shows you the journey of a patient for a proposed lung cancer or lung health check pilot, which the GPs are very much involved in terms of having an awareness of their communities and those who are at risk, inviting those who are in higher risk groups to come to the service, and then a lung health check. So typically people will have additional diagnoses such as COPD or chronic obstructive pulmonary disease, and so that is checked for. Smoking cessation is obviously a huge part of this, and then the actual CT itself. And then the outcome of that, of course, can be normal, or there can be a nodule and subsequent investigations required. And then there are serial CTs, depending on which program you see. It's been deployed in different ways. So I'm going to move on now and talk about something that's common to all screening programs. And Alan had that in some of his infographics, which is that participation rates. And so lung cancer is no different in this, and the experience really across the world has been varied, and it really speaks to the implementation challenge. So we've seen anything from single-digit participations in lung cancer screening up to 30 to 50% in some of the UK studies. And I should say that the UK is adopted as a national screening program now. But the challenge there is that, and again, you see this with many screening programs, is that those who probably would benefit most from screening are least likely to participate. And I've just listed some suggested areas there, and there's lots of research ongoing by us and others to explore this in terms of how to engage with those individuals. So engagement, yeah, so I mentioned that, and that's what this slide is about. So we've written about this, and you can read our BJGP article from just last month on that. But we've also begun to engage with the risk groups that we've talked about with stakeholders and community organisations and the Irish Cancer Society. And so we've been working with the Irish Cancer Society and patient advocacy organisations such as the Irish Lung Cancer Community to understand what would lung health check pilot look like in Ireland. So this was, again, kind of reiterating what Alan was saying, but in the context of lung cancer, which is the pros and cons. So no intervention is all perfect. There are considerations, and this is about that informed decision-making that patients would need to undergo prior to participating. So there's some efforts to do this, and this is one example, an infographic from the International Agency for Research on Cancer, which is based in France. And you know, some of this is intuitive, of course. If you scan lots of people are going to have very normal results, and that's what you're seeing with these green faces on the left-hand side. And then it's the other elements to this. Some people will have abnormal results in a CT scan, nodules that need further investigation, biopsies, and then there is, of course, the potential for harm from these biopsies. Then there's this concept of overdiagnosis, which is very difficult, I think, to appreciate for all of us. And it's probably more prevalent in other cancer types, but this concept that the cancer, while detected, may not have actually led to a mortality or morbidity. And so that is an issue in lung cancer as well. And then, of course, there is the lives that are saved from detecting early. What's not on this slide is another major issue with lung cancer screening, which is the concept of incidentalomas. So quite apart from lung cancer, you'll detect lots of other things. So coronary artery calcification, COPD, I mentioned already, aneurysms, and so on. So there's a lot of downstream effects of deploying this type of technology. And we've certainly been working with other groups to understand this in terms of implementation. Okay, but coming towards the end, this is probably my second last slide, just to walk through some of the challenges we've been working with researchers in the UK to explore as we begin the development of a potential pilot. I'll start with the top, which is around awareness, fear, and fatalism. So, you know, there's often this consideration about lung cancer being that so-called death sentence, and there's a fear. So really, it's a whole behavioral science there in terms of understanding, trying to work with stakeholders to understand what is their health literacy or understanding or motivations for participation, and that really is at the heart of any successful program. Moving right into the green box is primary care identification. So I've said to you that GPs are very involved in this, and it's often based on the routine health records that are collected. But of course, that's very dependent on those records being valid and accurate and so on. So the whole piece of work to be done to ensure that that piece of the puzzle is in place. Then invitation response, so how we engage with the public, what information is provided to them. Again, it comes back to, we've been working with some behavioral scientists in terms of understanding what are the push and pull factors and using behavioral theory to work on that. One that we're particularly keen on is risk assessment. So, you know, I haven't really given you the in-depth on this. I've said to you that age and smoking is our main drivers. Indeed, they are, but it's more nuanced than that. There's lots of other elements and indeed new technologies that Alan was speaking about in terms of AI that can be very useful in tailoring risk. So that's, I think that's a developing space. Decision support. So this is, I mean, this has to be at the heart of a successful program, which is allowing people to make informed decisions. So the infographic I showed you earlier on of all the faces is just one part of that. So working together so people can decide whether they want to participate in this program. And then finally, continued participation. I haven't labored it, but there is this idea that you have a baseline scan and then a subsequent scan, perhaps at 1 year, and looking for interval scans. But then again, there's a challenge there in terms of retaining people in the program and that they see the value to staying in it. So that needs work too. Okay, so last slide is to say where to next. So yeah, we are working on a targeted lung health check pilot, which has many of the elements that I've been telling you about, and I'm working with European colleagues and learning from them too, making it community-based, engaging stakeholders, using a mobile truck, having all those additional elements around COPD detection, having an integrated smoking cessation, and then doing this important, I think, implementation research, as well as some additional kind of biomedical style research as part of the pilot, so that we can understand those challenges and that we can be able to provide the evidence around any future potential rollout. And then a few kind of other points that I wanted to raise were it's just incredibly important in discussions with policymakers, with stakeholders, and with the designers, researchers, and so on, is about these ideas about access, equity, shared decision making, that we're constantly thinking about, you know, we're not creating artificial barriers and so on, or indeed that we're addressing them if they aren't there. The biomarkers and AI space, yeah, it's very exciting.
2 minutes, Patrick.
Thank you, Laura. There's some excellent things we could do here in terms of stratifying risk with biomarkers, or with AI in terms of additional clinical data, using that to image analysis and so on. And we are working with other researchers to see how that might be best used. I've said to you about smoking cessation. All the best programs internationally have smoking cessation as a part of it. It gives you the additional benefits from, you know, achieving smoking cessation. Training resources. So this will probably be for James and Ethna to take up, and, you know, we can discuss that later. But of course, there's a whole cost to new programs, and that needs to be considered in terms of where is that yield curve. Education and engagement. So education of yes, of potential participants, but patient navigators, healthcare practitioners, and so on and so on. All that work needs to be done. So that's it from me. Thank you very much. We're very excited about the potential for this, but also work on lots of other issues relevant to cancer and primary care. And so welcome to contact us or review the website, and we can discuss things further if you'd like to. Thanks so much.
Fantastic, Patrick. Thank you. And great to see the work ongoing to develop an Irish version. So we'll move now to our third speaker, who is Dr. James O'Mahony. And James is an assistant professor at the School of Economics at UCD, where he's employed as an Ad Astra Fellow. He also has a research affiliation with the Erasmus University Medical Centre in Rotterdam. An economist by training, James's research addresses the cost effectiveness of cancer prevention with a focus on cervical screening. James is a member of Ireland's National Screening Advisory Committee, and today James is going to provide a health economics perspective with reflections on cost effectiveness relating to his research around cervical cancer screening. So James, thank you.
Thanks very much. I'll just share my presentation. Hopefully everybody will be able to see that, and I'll just move to the full screen slideshow. Okay, so I'm departing ever so slightly from my brief. I'm actually not going to talk specifically about breast cancer screening. I actually want to talk a little bit more broadly about the role of screening and policy, and the extent to which policymakers are comfortable in using cost effectiveness analysis evidence. So that's going to be a slight departure from what the build talk. But so just to give you an overview, I'm going to talk about cost effectiveness analysis, the framework in general, and I'm going to talk about how that applies to screening. And then the guts of the talk is I'm going to focus on some of the CEAs of cancer screening that has been done in Ireland, including on cervical cancer, but also some others. And I'm going to talk about some screening programs that haven't been subjected to CEA. I'm a member of the National Screening Advisory Committee, and I just want to spend a brief time talking about my experience on that, given that it's important in influencing policy. And I'm going to have a quick aside on a technical detail in cost effectiveness analysis, which is the cost effectiveness threshold. So that's our bar for what's the value for money that we're willing to accept in the health system. And I can't give a talk without mentioning cervical checks. So at the end, I'm going to have a few comments on that in one slide. Okay, so just to talk about cost effectiveness analysis, CEA in general, the methods are very well established. They've been in their current form for about 40 years. And a key part of CEA is using the QALY, or the quality adjusted life year, as a measure to appraise effectiveness. And this is used in cost effectiveness analysis of drugs, but it's also used in cost effectiveness analysis of other interventions, including screening. And I'm glad to say that Ireland has been a relatively early adopter in comparison to other countries in using CEA, and we've got good infrastructure built up in the implementation of CEA. We compare favourably to other countries. So HICWA is responsible for publishing our national guidelines on how to do CEA. So we've got a very clear set of guidelines about how CEA is to be done, and that's important to ensure that we've got comparability between our analyses to make sure that our CEAs are done in a consistent way. And also importantly, the principles of CEA are recognised in Irish law. So there's the 2013 Health Act was aimed at cutting drug expenditure, but in that there's a legal recognition about how the HSE has to take into account value for money when it's funding new drugs. Now, this legislation is in the specific context of drug reimbursement, but arguably, I think you could say the principles apply more broadly. I'm not a lawyer, but I would fancy my chances of saying that you know what applies for drugs out of legal consistency should apply to other interventions as well. Importantly, though, this legislation doesn't oblige the HSE to fund anything that is found to be cost effective. So that's unlike the situation in the UK when NICE, when it finds an intervention is cost effective, there's an obligation on the NHS to provide that intervention, and we don't have such a provision here in Ireland. And as I've alluded to, CEA is most routinely practiced regarding drugs. We've got a very, very well developed drug appraisal framework in Ireland, and that's implemented by the National Centre for Pharmacoeconomics. That's based out at St James's Hospital and has affiliation with Trinity. And that's just a sort of a quick screenshot of some of the staff who work out there at the NCP who are so able in appraising new drugs that come into our system. So CEA can also be applied to screening, and internationally it's well established. Now we can apply CEA methods to screening as well. And the way that we typically do this is we use simulation models. So while drug-based CEA is typically working closely on trial-based evidence of the performance of drugs, when we do the appraisal of cancer screening interventions, we typically rely more on models. And what we do in those models is we simulate the natural history of the disease. That was a little bit like what Alan was talking about earlier on, about the development of the disease from an early stage up all the way through to cancer. Now, it's difficult to simulate the natural history of disease. We have to get a lot of information on this process that we don't observe directly. We have to use lots of different data sources. We have to combine them rigorously, and we need to calibrate these models. So building these natural history models is no mean feat. Then we impose our estimates of the screen test performance to try and generate our estimates of many outcomes, including how many true positives are we finding at a particular round of screening and how many false negatives are we generating. And we can use that to then estimate how many lives are we going to be able to save, how many people are we going to miss, and what's going to be the effectiveness of that screening program, but also not just that program, but lots and lots of other different strategies. And we compare the net cost and net estimates of effectiveness in terms of qualities of a range of different strategies, and then we pick the most cost effective of all of those different strategies. And one of the reasons why we want to use simulation is we want to simulate a very broad range of strategies to pick the best strategy. Okay, to review some of the CEAs that have been published in Ireland, and I'm concentrating on those published by HICWA since they're the CEAs that are most directly influential on screening policy. So I'll start first with the 2009 HTA of colorectal cancer screening. So this was very important for the establishment of BAL screen. So this was useful in determining what testing technologies we were going to use and how frequently we were going to screen. An important constraint on that analysis was that we don't have the colonoscopy capacity to do the ideal amount of screening. So that analysis looked at relatively conservative screening strategies and only considered a relatively small number of strategies. So the image that we see here is what we can see here is a cost effectiveness plane, and it's the different strategies that have been considered in that analysis. And what we're seeing here is that there's only a small number of strategies included in that analysis, and that small number of strategies considered will influence what's going to be the optimal choice. So some work that I'm very proud of that I did with Ethna, who'll be presenting later on, is on this work on colorectal. She might be talking about it, so I won't go into too much depth, but basically we looked at a broader range of strategies and we found that we could do better even if we had the current endoscopy capacity. But maybe more broadly, the important point was that ideally we'd like to move out to a much more frequent screening program with a much broader age range if we didn't have a colonoscopy capacity constraint, because frequent screening over a broad age range much more intensively than we do so currently in Ireland would still be cost effective. So we are currently very far under our optimal screening intensity when it comes to colorectal cancer. So moving on to consider the 2013 HTA by HICWA women have a high risk of breast cancer. So these are women who've got a known reason to expect that they're elevated risk of breast cancer, and we would provide intensivized surveillance of these women. So I have a technical complaint about the way the cost effectiveness ratios were reported in that study, but I don't want to dwell on that. This is just the cost effectiveness plane that was produced in that study. It's explained the difference in the ratios, but I don't really want to dwell on that. But the strategy that was more or less recommended out of that CEA was very far above what we would consider to be a cost-effective strategy. So this is a policy recommendation which seems to be very much departing from what would be considered cost-effective. Now, this report is from 2013. I understand that the recommendations from this report still haven't been implemented, and I don't know what that means for surveillance strategies for these groups of women, but it's likely to mean that there's a situation where we've got heterogeneous practice across the country, and that's one of the things that I think health economics is trying to avoid. Anyway, so I'll move on there. So now I'll consider the more recent, the 2017 HTA of HPV testing as the primary test in cervical screening. So this showed that moving to HPV testing is going to be more cost effective than sticking with the old liquid-based cytology-based primary testing. So that's good news. One thing that this analysis didn't do is it didn't consider a broader variation in the screening intensity in terms of a large range of different screening intervals or different age ranges. And that causes a difficulty because when we want to do cost effectiveness analysis, ideally we want to look at a broad range of strategies, and this analysis didn't do that. But even within the range of screening interventions that it considered, it did find that the current frequency and the age range that is employed within cervical check is too intensive to be cost effective. So if we wanted to ensure that cervical screening is as cost effective as it ought to be, we would need to reduce the intensity. We would need to increase the intervals between screens, and we maybe would need to reduce the screening age range. And that's not going to be a politically welcome message for any policymaker to sell, which is a difficulty. Now I want to talk about some screening programs that haven't been subject to CEA, and the first is breast screening. So we've got the breast check program, but it's not been subject to a CEA in Ireland. I think Alan has already alluded to this, that the effectiveness of breast screening is very, very hotly debated, and it's very, very difficult to get a straight answer on how effective do we think breast screening is. If you ask different people, they'll give you different answers, and that causes a difficulty. I'm not an epidemiologist, and I find it difficult to negotiate those debates when I read them. And just as an example here, just reference a recent paper by Moran and Cullinan, two economists two health economists, and they looked at the evidence that came out of the phased implementation of breast check that Alan had mentioned earlier on, and they don't find any disease-specific mortality benefit from this phased introduction. Now, we can have a big discussion about, is the design of that study appropriate and so on, but it's just one example of the varying views that are coming out from different data sources on the effectiveness of breast screening. And I know that might be something that seems quite counterintuitive to a lot of people, but if we're spending a lot of money on these services, maybe we need to think carefully about what is the evidence for the effectiveness of them. Now, if I look over the cost effectiveness analyses of breast cancer screening that have been published internationally and academically, generally they're all quite old and they're of mixed quality. So I don't think they provide a very good basis for telling us that the type of breast cancer screening programs that we implement in Europe are likely to be cost effective. And then as a specific example of a recent policy decision, well, a relatively recent policy decision, the decision to extend the upper bound of the breast check screening program in 2015, that wasn't backed up by any cost effectiveness analysis. So we're making some policy decisions here that aren't being subject to CEA. So Patrick has been talking about lung screening. So you mentioned the RCT evidence demonstrating its effectiveness. This is good news. The CEAs that have been published recently also indicate that it's cost effective, so that's good as well. Now, there are still questions about the optimal intensity and the risk selection. So this is a paper that I published last year with some students We were looking at the different interventions that are being considered. And this is a figure that I only published as a research poster after I published that paper, and I wish I had used this picture, but this is an illustration of the different screening intervals that have been considered in CEAs of lung screening to date. And what we see is a lot of CEAs here have only considered one screening interval, so they haven't compared different screening intervals. And that doesn't really give us very sound evidence for saying that that particular screening interval is likely to be the best screening interval, because they've only assessed one screening interval. These interventions, these models up here have considered a range of different screening intervals, and they give us maybe a better view of what might be the optimal screening interval. And there's no consensus here. Is screening every year, every 2 years, or every 3 years? There's no clear consensus, so that it's quite unclear about how often should we be screening people. And there are also analogous questions about the best mode for risk selection amongst those populations. Now, Patrick has already mentioned the social gradient here. I think that, you know, it's important that we get lung screening right. There's an important policy significance of trying to alleviate this very substantial mortality benefit, mortality burden, pardon me. So finally, I just want to mention prostate cancer screening and triage here. So prostate cancer screening isn't currently practiced by the National Screening Service, but it is. PSA testing is widespread. Many men go to their doctors and they get a PSA, and if they have an elevated PSA, then they fall back largely on the on maybe their private health insurer or on the HSE. There's a bill for the subsequent triage for the workup for men who have an elevated PSA. If I look at the CA evidence, I see a really mixed picture versus whether prostate cancer screening is effective and cost effective. And this is even the case, even if primary screening was costless. So even if men were paying for their own primary screening testing and then the HSE picked up afterwards doing the triage, even if we assume that the primary screening was costless, it's still unclear whether or not prostate cancer screening represents value for money. And there's an obvious equity question there. If you have certain men, maybe wealthier men, who are able to buy their primary test, their PSA,
14 minutes, James.
and then they get the HSE to look after them in the triage. I think that's dubious to me in terms of its use of funds. Okay, I want to talk now briefly about the National Screening Advisory Committee. So, and my experience of it. It was established in response to the cervical check controversy on Gabriel Scali's recommendation. We have 19 members and we meet quarterly, and we review proposals that come to us about how different population screening programs may be introduced or changed, and these include cancer screening, but there's many other programs other than cancer screening. And we're very grateful for the support that we get from HICWA's new screening unit. So there's a dedicated screening unit within HICWA that reviews some of the evidence for us and does some of the hard work of churning through the existing published data. I've two big observations here. The time to review the evidence is limited, so we're kind of an unpaid committee. This is work we do. We come together and we review this work, and sometimes we've got a lot of things to go through, and it's difficult to get a good grip on the evidence there, and it's hard to do a good job in a short space of time, I would say. And this is, I want to clearly flag this as an opinion. I think if you want to get cost-effective interventions being recommended by NSAC, then you need to have vocal health economists on the committee. It has been my experience that clinicians want to introduce screening programs in their area of interest, and they're not really that interested if it isn't showing up to be cost effective. Will look for rationales to ignore the cost effectiveness evidence or override it. I don't think that's a health economist's paranoia about being ignored. I do think that's a real experience of mine on the committee. So I think people often like to override cost effectiveness analysis evidence. Very briefly, I just want to talk about the cost effectiveness threshold. This is this decision rule that we use to work out whether or not something's cost effective. This has explicitly been stated for drugs in Ireland, and the limit is being, thank you, Laura, as being €45,000 per QALY. Now, its current status is a little bit unclear. It's not as clear as it used to be. This threshold, even though it is being stated clearly in the in the context of drugs has never been explicitly applied to screening. There's no evidence behind this threshold, so this threshold is more or less a guess. It's probably too high, so I've published on that previously, indicating why there are maybe some unmet needs within the system that are probably more cost effective than the threshold. So we're probably spending a bit too much money on drugs here. And I think this is problematic because, in principle, other interventions like screening aren't being treated on a par with drugs. Now, in practice, it's something different because we've seen that there are interventions which either haven't been appraised in the CEA framework, such as breast screening, or when they have been appraised, such as cervical and that high-risk breast cancer screening program, the policy recommendations are for strategies which are above the cost effectiveness threshold. So what happens in practice is different, but in principle, there isn't parity here between drugs. And there's a broader problem here that if this cost effectiveness threshold that we're using isn't based on any evidence, then the overall policy recommendations that are coming out of our analyses aren't evidence-based policy recommendations, and that is an issue. Very briefly on cervical check. So I think a huge amount of the problems here came from the Irish media. They left people with some very, very mistaken impressions. You know, people believed that women were knowingly left with cancer. That's not true. People are left the impression that the test performance was very, very substandard, or that the outsourced tests done in America were inferior to the ones done in Ireland. I don't believe the evidence shows that at all. And I think there are some really serious ethical questions regarding responsible reporting. If we think about if we were doing a research project and we have to go through ethical hoops, you know, to get ethical approval for our projects, we're really held to very high standards, but yet journalists can knowingly or otherwise mislead the population and cause huge trouble for screening programs. But there's no recourse to them, or there's no control on irresponsible reporting. And even when I've addressed journalists to point out inaccuracies in their reporting, they've been very, very unapologetic on the most part about that and don't seek to correct it. So that is a big problem, but I'm possibly digressing. The political response to cervical check, I don't think helped. I think from the politicians in power, I think there was panic, and from opposition politicians, I think there was a lot of grandstanding. We're left with this incredibly expensive legal legacy, as Alan has alluded to. And I think the political will to revise cervical check, to move ourselves back to a more efficient configuration, I think that's probably gone. I don't see anybody willing to take the tough steps that would be needed to de-intensify cervical screening, and that will count when we move into vaccinated cohorts of women. And I think we're also going to be left with a lot of uncertainty regarding the liabilities regarding the introduction of lung cancer screening. Many people have already commented on that already. So this is going to matter. Okay, my conclusions. So to do a CEA, it's very technically demanding. You need a lot of expertise to do it. Fortunately, Ireland has got a lot of the key aspects of CEA infrastructure already, and I think that's really a good thing. But my frank view is that I think the policy influence of CEA evidence is very, very limited. Now, I think regarding capacity planning and things like that, I think they can be useful. But I think the ethics of allowing CEA to languish I think it's extremely questionable. I think we need to grasp this nettle, and we need to start thinking about efficiency in a more constructive, critical way in Ireland. Thanks very much.
That's great, James. Thank you very much. And just in the interest of time, I'll move quickly to our fourth and final speaker today, who's Dr. Ethna McFerran. Ethna holds a PhD in cancer health economics. She spent over a decade practicing in oncology and has led groundbreaking research using discrete choice experiments, cost effectiveness analysis, and microsimulation modelling to shape healthcare strategies. In her current role as a postdoc research fellow at the Patrick E. Johnston Centre for Cancer Research at Queen's University, Ethna spearheads projects that bridge the gap between cancer research and health economics. And today, Dr. McFerran will speak about her modelling work within colorectal cancer in the UK and how such modelling analysis have the potential to impact screening programmes and provide input to the debate about future aspects of those programmes. Thanks, Ethna.
Fingers crossed I deliver all that. So I was recently at a course on storytelling, and so I'm endeavouring to try out a new version of presenting, so indulge me. Think to yourself here in the small pause between these sessions about how long it is until you turn 55. or you may already be there. As many of you know, there are lots of people who publicly have acknowledged that they've had a bowel cancer or colorectal cancer diagnosis. I was going to try and play in the Cheers theme song here for Kirstie Alley, one of the most recent. But of the people shown on screen here, Chad Boseman, Audrey Hepburn, Ronald Reagan, Sharon Osbourne, Ruth Bader Ginsburg, Kirstie Alley, Pele, Julie Walters, the Queen Mother, and Tina Turner. Only one of these people has, from what I can scour through the internet and find, potentially being diagnosed via screening. And if you want to in the chat, you can add in your guess as to who of those that might be, and I'll tell you towards the end. So, as James alluded to, and I won't go into all the depth, maybe that some of the nuances that James described, we did do an evaluation of the Irish screening programme in the context of some of the issues that he raised in terms of the previous HICWA evaluation, and that we did that in conjunction with Erasmus and the Memorial Sloan Kettering Cancer Research Centre during my PhD, which was funded through the NCI All Ireland Consortium. The HICWA strategy that James mentioned assessed 3 different potential technologies using only 2-year intervals and 3 specific age ranges for each of the tests as listed here. And they plan to use a 100 nanogram cutoff. Capacity constraints initially were not considered, and at that time they identified a 55 to 74-year-old as the target age range. And unfortunately, they were subject to capacity restrictions when they tried to implement the programme from 2012 onwards. And so quickly, they conducted a capacity planning analysis to inform their 2012 rollout, at which point they decided to restrict the age range to 60 to 69-year-olds. And again, very quickly after the rollout, they discovered that that too was beyond the existing capacity. And so they made a decision to adjust the threshold to 225, so thereby lowering the positivity rate from 8% to 4.1%. For those of you not vastly familiar with the concept of the fit threshold, I liken it to having a dimmer switch rather than a big light. So the FOBT test would have been a big light, it's either on or off, but in the context of FOBT or fit, sorry, we can use this test a bit like a dimmer switch and switch it up and down a little bit. But what we know from the cost effectiveness evidence, even as early as 2011, just prior to when the SHARP analysis was conducted, is that lower thresholds are always more cost effective, but they have a greater capacity impact. And so as a consequence, with this dimmer switch, what we can see is that the specificity changes, but the level of adenoma detection also changes. So whenever you push to that higher level of 200, you bring in less adenomas, and I call them the mortgage on future prevention. And you don't really have a significant body of evidence to back up that decision. And so we tried to examine whether there were other ways that that capacity constraint could have been handled using, as James had mentioned, that microsimulation modelling approach. We were fortunate to be able to collaborate with MISCAN, one of the international leaders on cost effectiveness analyses for screening, and we were able to use their model to demonstrate potential alternatives for Ireland. So we set out to examine at least, and I think we actually ended up with more than 315 comparisons of fit cutoffs, screening intervals, and start age ranges to generate all the various outputs from that model, with a specific target to try and identify, as you'll see here, the strategies which are darker are those that would also be possible within the existing capacity. And James has shown you the graphic before, so you shouldn't be too alarmed by what you see here. But what we know is from that modelling exercise that the circled area is actually the most effective strategy. So if this were a drug, that would be what you aimed for, and you would aim to deliver an annual fit screening with a 50 threshold to 45 to 80-year-olds. But we know that there were 126 alternative strategies that were still possible within our existing capacity. And then we sort of, as you'll see, zoom in a little bit in this evidence to try and understand of those what had happened. So position 1 is where the original 2009 HICWA analysis led us to. Decision point 2 is what happened when we took the age restriction from 55 down to 60. And then we went back to point 3, excuse me, when we got to the 225 cutoff. And at each of those points, as you see, we stepped back in terms of the effect and in some cases also reduced the cost. But there are alternative positions that we could take, and each of those are identified as you'll see here. So if we moved out to point A, that policy uses a fit 50 every 4 years, and that would be in the ages 60 to 72, and it's feasible within the existing capacity, and it improves the outcomes and reduces costs and prevents about 13% more deaths than the current strategy provides. Another alternative would be to move to point B, which again provides a fit 50, but every 5 years between the ages of 55 to 75, which was like the original intended age range. And again, it's feasible within existing capacity. It improves outcomes, but it slightly increases the costs, but it prevents 29% more deaths. Finally, point C would use, again, a fit 50 every 4 years between 50 and 74. But this is where it requires a capacity extension, which is what has been planned in the identified 2017 Irish Cancer Strategy. It improves outcomes and increases costs, and it prevents 5% more deaths than the existing planned expansion. So all of this is to say really that, as James has identified, the use of cost effectiveness analysis, although it is often applied at the beginning of programme planning, is really very vital in terms of making adjustments to planning as there are changes to circumstances and specifically capacity. But we shouldn't really overlook the overall policy objective of trying to achieve the most effective drug within our overall quality threshold, and that would in fact be moving to position D. Which would provide an annual screening between the ages of 50 to 80, but it would require a vastly expanded capacity. So the table's laid out here, and it shows obviously the specific numbers there. The desire to change the interval has often been muted as one that might be intolerant to patients in the public because it would require some revision of their thinking. But I think given the arguments here for the improvements in outcomes, I think we need to have a bit more effective conversations with patients in the public to try and understand their values and opinions in terms of the outcomes that they're seeking from participating in screening, especially given that the overall attendance for screening as monitored by existing KPIs for 2022 shows that it's 43%. So the lessons we learned here are that we shouldn't limit strategies before comparison, and that comparator omissions are often relevant both within and beyond capacity constraints, and that it should be an integral part of planning to consider cost effectiveness analysis in order to ensure that the decision maker is prepared to make an informed decision, and that we should really consider the intensity changes to ensure that we achieve the kind of coverage that we need. So these results effectively, which have been presented to the screening programme previously and published already, show that we have the potential to save more lives and money within existing capacity restraints, and that we really do need to consider consultation with both endoscopy committees and the Irish Cancer Society and beyond. And I just checked as we were chatting there, as I mentioned, the bioscreen uptake is monitored on an annual KPI output. And as I see here, the target is 60%, but it's currently sitting at 43%. But I note that the Irish recommendations from 2017, which are due to expire in the next 3 years, was to try and expand that capacity to allow us to deliver the originally planned 55 to 74-year-old interval for screening, and there is no measurable KPI to demonstrate achievement against that outcome. So that sounds alarming, to say the least, but we're not alone in that. So James and other colleagues, Rajani and Ishu and myself, also conducted a systematic review to look at this issue, just recently published there in June, across Europe. And what we were able to see is that we're not alone in making these kinds of decisions. Similar to the figures that James has shown already, the review helped us to see that many other countries have conducted cost effectiveness analyses to inform their colorectal screening programmes. And as you'll see here, the majority have stuck to this 2-year interval without consideration of other intervals. But what you'll see from the white shaded ones or the unshaded ones is that the actual most cost effective, or if you were to consider this in drug terms, the best dose would be to have an annual screening invite. And so it is alarming to see that in the context of screening, as James has alluded to, that we are satisfied with delivering suboptimal outcomes for our investment. In the context of the FIT cutoff, you'll see here again that the number of studies that examine a wide range of thresholds is quite limited. You'll see myself listed there among the top few that have done. And again, the unshaded areas define those that are the most effective, and they tend to sit much lower than what is actually implemented in many countries. And so I say that in context of my original question, which was how long do you turn 55? And now I kind of bring it down a bit and I say, how long do you turn 45? Because that's where the cost effectiveness evidence is suggesting that we should be leaning to. Although we've aimed for 55, the most effective dose of screening is delivered for those starting at an age of 45. And what we saw from the review is that many of the age ranges included did not actually go below the 50-year-old age group, but that the actual most optimal start and stop ages is between 45 and 50, and between stopping ages of 74 and 80 in the cost effectiveness analyses. Over and above that, the most simulation estimates indicate that a 10 milligram threshold rather than the 225 in Operation Ireland is optimal, but it's only used in one area of Burgenland. Other areas in Germany and Lithuania also feature cutoffs as low as 4, but that's not programme-wide. And indeed, even alluding to the Dutch area, where we know that they are specialists in this particular type of analyses, they also report 20 micrograms, or lower to be optimal, but they themselves implement a cutoff of 47, again, much lower than that of Ireland, all again focused on these capacity restrictions. So in conclusion, with both these programmes of work, we can see that many European and indeed Irish programmes do not have sufficient age ranges for screening and other elements included in their analyses, implying that the majority of European screening programmes are likely to be of suboptimal intensity, and that more lives could be saved if programmes were to be able to move towards an annual offering. So with that in context, it's clear that the challenges are around capacity, and the main capacity limiting factor there is colonoscopy. In Northern Ireland here, we have a significant number of red flag targets, wait lists, and those times have increased between those, especially in context of cleaning and so on from COVID. And we've had the transition to FIT in our screening programme in the UK and in Northern Ireland. You were fortunate to have it start in 2012. We started 10 years later in 2022. So we too have a long-term vision of expanding the age range. We were fortunate to be able to roll out FIT triage in primary care to try and make better use of our resources and plan tools to build into the Encompass. So change is what I think is the main message coming through from a cost effectiveness perspective, and we are trying to work in as many ways as possible to try and ensure that we can support and advocate for that. And cognizant of the issues that Alan raised in terms of the potential for overdiagnosis, we don't see that as often in the case. Thanks. I want to rattle through this, but the survival route matters. 10% of patients are diagnosed in the Northern Ireland via screening, and 94% of those will survive via emergency presentation, and it's as low as 40% via red flag. That drops down to 71%. So in Northern Ireland, we've set out a project cognizant of the COVID impact, with the vision of building an international comparable model, which is fully user-led and connected data streams from the registry as well as from the services, and that is policy-based but future-enabled in order to predict costs and benefits for service design and reconfiguration, to be able to address issues like inequity and personalisation, as well as contribute to obviously national and international publications. So where we're at with that is we designed a dashboard in R, and it's embedded text mining from clinical data and created loops to try and understand missed cancer feeds, and we have that survival by route as shown in the previous slide embedded, and we provided that in a policy-friendly way. So this is an example of what that will look like or be available to, and we've used some COVID data here to show some of the dips that have occurred there. And the interim findings have shown that during COVID, the number of colonoscopies carried out in over 75s was much lower, but that overall the increased conversion rate by the implementation of fit triage has been useful and has had the potential of lowering the proportion of negative colonoscopies, offering us the potential to expand our screening offering. So we have to consider how best we can balance that against the wait lists for the red flag clinics. So the ongoing work is where we're matching the colonoscopy and fit data from the COVID period, and there's grants submitted for that. And PhD work is ongoing, looking at imputation from that routes to diagnosis survival to try and understand the impact of COVID, and actively partnering with the Public Health Agency to examine those survival rates in context of COVID. And working closely with James now at UCD, I should note, and Erasmus for calibration against our model from MISCAM. To date, this work has received funding, as I've mentioned, from the NCI All-Ireland Fellowship, Cancer Focus Northern Ireland Health Data Research UK, the ESRC, and thanks to all of the various people listed, and once again, thanks to Jan and the colleagues at RCSI for the invitation to speak today.
It's fantastic, Ethna. Thank you. And if all the speakers could turn their cameras on, that would be great. I'm conscious we just have 8 minutes, so and I'm also conscious that there was a lot of questions in the chat. Clearly, we're not going to get to them all, but I know Alan put some messaging in there around going to the screening services website for lots of blogs and more information if people want it. So I'll at least try and get one question into everybody before the cutoff. So Alan, I might start with you since you've had a break. Obviously, you've worked across the screening programs over the course of your career, and as we've seen across the presentations, screening is not something which stands still. It's constantly evolving, and there are many decisions to be made about where we go into the future. Can you tell us a little bit more about, and obviously we heard about the NSAC from James, but can you tell us a little bit more just about the process and governance for screening in Ireland? Who makes decisions about new programs, changes to existing programs, and what the process is there? Thanks.
Yeah, sure. And James indeed mentioned, I suppose, the most important group. So any changes to existing programs, be it breast check or cervical check or whatever, must now be first evaluated by the group that James referred to, and it's the National Screening Advisory Committee. So it's independent of the HSE and the National Screening Service. So we can't go off and do something without their imprimatur. That committee has a multidisciplinary makeup. James alluded to them, and to cut a long story short, that ultimately it is their job to make recommendations to the Minister for Health and the Department of Health. And if he or she accepts them, then these recommendations will be communicated to the HSE. And obviously, if there's anything impacting on breast check and cervical check or bowel screen, then we crack on with implementing that. So a good example would be, and I saw it in the chat, a good question around breast density. It's very topical. I know an application has gone into the committee in relation to reporting breast density as part of a national screening programme, but I'm not aware, and I don't have any sight of any deliberations in relation to that. I think it's fair to say it's a good question from Siobhan in the chat, that it is very topical at the moment, but it's not as if it's not within the gift of breast check to simply start reporting breast density. We can't do that. It is true that European bodies have recommended that we should start reporting that, but to a limited extent. That the same group that recommends it, it's also fair to say that a considerable amount of work would have to be done to go into the planning. So we have to be able to answer this important question around what do we do with every woman that comes into breast check. that might have varying degrees of breast density. Okay, we might have answers for very high dense breast women, but we need to know the answers for the others, and we need to be able to do it consistently and cost effectively, as James said. So we will do what our evidence tells us to do, and right now we're waiting on the evidence to inform NSAC, and once NSAC tells us what to do, we won't be lacking on the screening side to implement that. I can assure everybody of that.
Thanks, Alan. And I suppose maybe Patrick, I'll come to you when the evidence leads to a recommendation and the screening program implements, then of course there's a whole range of considerations around implementation. And long before that, you're considering those issues obviously as part of what you're trying to do on a pilot basis here in Ireland. And so I know in particular you focused at the end on equity and equity of access. And maybe I'll just ask you to comment on a little bit more about the potential equity issues that arise around implementation of what you're trying to do.
Yeah, thanks, Ronan. So it's a real challenge, isn't it? I mean, if you want something to be successful, then you really need to get buy-in. And so it's about putting in the groundwork in the beginning. And I also think that's why it's taken us so much time to get this done, but I think it's absolutely worthwhile. And certainly our experience from reviewing the evidence from abroad is that those, if I relate it specifically to lung cancer, the ones that are co-designed, I know that's used a lot at the moment, that phrasing, but if you do that work, if you speak to the stakeholders, you understand what are the barriers, then ultimately you have a better product, if we forgive the phrasing, in terms of what you ultimately offer in terms of a service. So that's certainly what we're doing at the moment in terms of going out, and we have a number of research projects that are doing that in terms of working with behavioral scientists and then the individuals who would be affected by that to understand these issues. You know, the model is different as well. I'm conscious that it's much more tailored. It's quite looking at particularly at risk populations, so it needs that individual approach to understand that, and so that's again why it's worthwhile doing this preparatory work. Yeah, so I'm quite pleased, but it takes a lot of effort, and I just wanted to pick up on a few things that are in the chat as well, if you don't mind, Ronan, in terms of personalizing risk. So one comment I think from Kathy was about, you know, the involvement of general practice and the use of AI and IT and so on. We're very live to that, and we actually have research projects working on exactly that, Kathy. So I'd love to take up that conversation. But what James and Ethna have said is so important, that ultimately whatever the evidence that we're providing, the data we're gathering, it needs to go through that formal process of evaluation so that we can give good recommendations. And I think another contributor talked about that, ultimately that translation into policy, that we need to also be thinking about how we can put that evidence in front of policymakers and ensure we're heard in terms of making the right decisions.
Thanks, Patrick. James, I'll come to you just on a concern you raised at the end, and maybe just to speak about it in general terms as opposed to any one experience we've had over recent years, but the issue of responsible reporting. And, you know, do you have suggestions for how we would, or how we might address it, or how other countries or organizations internationally have approached it in terms of the relationship with the media and reporting around these issues?
Thanks for the question, Ronan. I don't know about international experience, but I think people working within the system got caught off guard and didn't have training to deal with this. I imagine people may be undergoing training to sort of deal with the media, but it's an incredibly difficult thing. I listened in the initial weeks of the cervical check scandal, and I heard on the radio, mostly coming on, medical negligence lawyers were the people coming forward, and there was a large community of I thought senior clinicians who could have come forward, but I completely understood why they did not come forward, because, you know, there was just an awful lot of mud being slung around and people don't want it to stick to them. And so I think it's understandable why people don't come forward to kind of correct the message and so on. But I think I've personally tried to push back against the journalists to say that this reporting is unhelpful, and I think those of us maybe in the broad scientific community need to engage with them so they can understand their responsibilities on this. So I think that might be the first thing that we can do, is to communicate back to journalists, and some of them get it.
Thanks, James. And Ethna, I'll come to you. Obviously there was a huge amount of data in what you presented, and very interesting analysis. I guess one question, and sorry, just to say as well, I think it's really good to see the whole of Ireland collaboration and approach to these issues. It hopefully signals the direction of travel for further cooperation on health.
Don't comment on that, but
sure. My question specifically was just around how you've incorporated the views of patients or other stakeholders in your assessment and conclusions coming out of the analysis that you've been doing.
Thank you for the question, Ronan. I think it's the most important thing, you know, given the issues that have been raised with cervical check and the issues that Alan alluded to at the start in terms of overdiagnosis and ensuring that we bring the whole population along with us. Screening is one of the areas, having worked in the clinical setting for a long period of time, it's very easy to get or more readily easy to get patient user involvement for someone who's already been exposed to a condition and has an experience of it. But in the screening setting, it is much more challenging because it's healthy people. It's you and I. That's why I said, when are you 55? When are you 45? Ronald Reagan was the only person who was actually identified with his bowel cancer, and it was incidental through follow-up examinations in the 90s, and screening hadn't actually been rolled out. But we are fortunate we have a stakeholder who has had bowel cancer but is really engaged with staying in the context of screening and how we can expand out the offerings from that side to try and promote the early diagnosis. And it's certainly something, if anybody in the audience is willing to, you know, from a patient perspective, you know, to engage with any of us, do reach out. But that's one of our biggest challenges. We're targeting healthy people, as Alan said at the outside. They're asymptomatic. But we know that the trends are moving towards earlier aged diagnoses, and the tip-off from people who are being diagnosed in their later years because of the impact of screening is reducing. So it's really important that we do, you know, prioritise patient and public involvement in all aspects of our screening programme and evaluation. So we're very fortunate to, at least, to have a couple of secured people for our committees and stakeholders.
Thanks, Ethna. So I'm just conscious of time, so I think we'll wrap there. But as I said, I really want to take the opportunity to thank the four of you. I think it was a really engaging, interesting, thought-provoking session today. And I think we could have gone on for quite a bit longer in terms of the debate around some of the issues raised, to be honest. Maybe just a message to the wider audience. It was great. I think we had 160 people on at one stage today, which is fantastic. And just to say that we'll communicate prior to the next webinar, but as Jan said, it'll be mid-November, and the topic will be around diversity, equity and inclusion in cancer care. So thanks again to our speakers and to everybody for dialing in today. Great session, and we'll see you all in November, hopefully. Thank you.
Thank you.
Thanks, Ron. Bye-bye.